Good afternoon, everybody. Thank you for coming out to our Lunch and Learn for this month. So this month we will be talking about for this session we'll be talking about telemedicine. So we have two speakers, Dr. Krupinski. She will do an introduction to telemedicine 101 for clinicians, and then Dr. Singh will talk about nutrition, telemedicine for metabolic nutrition for therapy. So I'm going to go ahead and introduce Dr. Krupinski. She is a professor and vice chair for research at Emory University in the Department of Radiology and Imaging Sciences and subject matter expert for the Emory Telehealth Program. She received her BA from Cornell University, her master's from Montclair State, and her PhD from Temple, all in experimental psychology. Her interests are in medical image perception, observer performance, decision making, and human factors. She is Associate Director of Evaluation for the Arizona Telemedicine Program and co-director of the Southwest Telehealth Resource Center. She is the past president of the American Telemedicine Association, past chair of Society for Imaging, Informatics, and Medicine, past chair of the SPIE Medical Imaging Conference, and president of the Medical Image Perception Society. She is co-editor of the Journal of Telemedicine and Telecare and is on the editorial board of the Telemedicine and eHealth Journal. She will be presenting today on Introduction to Telemedicine for Clinicians. And she's also co-PI for our CERN Hersagram, which I almost forgot.
All right, good afternoon, everyone, or good morning, depending on where you are. It's a pleasure to be here. I'm supposed to look this way, not this way, so I'm not turning my back to you, but I was told to look more at the camera. So I'd like to just kind of give you a brief overview of telemedicine with a really basic 101. There's a lot of confusion about what telemedicine is versus is not. It really is not a separate subspecialty. And a lot of people get confused about this and think it requires a separate degree, separate training, and so on. It does not require any sort of separate degree. I think it requires training, but not from the medical side, more from the manufacturer side. And what it really is just a transfer of medical information using a variety of telecommunication technologies. They can be stored forward, they can be real time, they can be iPhones, iPads, complicated cart systems, as we call them, for consulting or remote procedures or exams. And it really has permeated practically every clinical subspecialty. Now, if you are new to telemedicine, I recommend these three books, as if not all of them. The first one is a book by Rashid Bashir and Gary Shannon that really tells the history of telemedicine. It's more a U.S.-centric. It doesn't do a lot with international telemedicine, but it's an incredibly interesting and informative book, very easy to read. The second book is one that Karen Ruban from the University of Virginia and I put out last year called Understanding Telehealth, and this really gets into a whole variety of clinical subspecialties, talking about state-of-the-art in most of the subspecialties that are really pretty heavy into telemedicine. It also has some on international policy research and so on. The last one is one that I wrote with Neil Charnas and George Ramirez on sort of the human factors of telemedicine. It was specifically for aging populations, but a lot of stuff that we talked about in there is really useful for setting up, designing telemedicine rooms, and how to take into account for the human factors side of telemedicine when you're doing it. Now, again, for sort of the history of telemedicine, this is usually considered the beginning of modern telemedicine. If you read that first book, telemedicine really goes way back even to smoke signals. It's one I consider communication across distances. But this is Ken Bird. He was a physician at the MGH, and there was a service that the MGH provided to Logan Airport where they manned the clinic out at the airport for travelers and folks who were getting sick at the airport. And if you've ever been to Boston and tried to get from MGH to the airport, which is less than 5 miles, even back in 1960s, it could take like forever. And even now, with the big dig and the tunnel and everything, it still takes forever. So he said, bag this. I'm just not really interested in trying to beat Boston traffic. And he set up what is generally considered the first actual telemedicine facility. There was a nurse at the hospital at Logan Airport, literally with a TV camera, as you can see, and he stayed back at MGH and used these little TV screens where he was shown on one of the patients and on the other. And that literally is the beginning of modern day telehealth. Well, the aspect ratio is slightly different on the slide, so I apologize for the smudgy text there. Telehealth really isn't. People consider, telehealth versus telemedicine. What's the difference? Telehealth is an overriding umbrella that encompasses all of these little things, including telemedicine. Telehealth encompasses education, distance learning, public health, research and assessment, patient education, homeland security, disaster relief, and all sorts of things. So it's an overriding umbrella, where telemedicine is typically seen as the implementation of the actual consulting between providers and or patients regarding their conditions. Why do people want to utilize telemedicine? There's just so many benefits. There's a lot of folks out in rural and even in urban areas that simply don't have access to medicine in general, medical services. There's a lot of professional shortages in various clinical specialties. More important than that, there's a maldistribution of professionals. Everybody wants to work in the city. Nobody wants to work out in the middle of nowhere. Specialist shortages as well, health professional education. People would rather travel to Hawaii to get their CMEs, but that's not always possible. Travel times can be very inconvenient, getting physicians and patients in the same place at the same time. Healthcare costs are increasing dramatically, so we're always trying to find ways to save money. We have an increasingly aging population, and those with chronic conditions, diabetes, COPD, just a number of things where people really need more medical attention than they did in the past, but you don't necessarily have to see your providers in person to get it. You've got patients with special needs. Disaster relief is huge. There's been a number of recent disasters, hurricanes, earthquakes, where telemedicine has been implemented quite readily to help those populations. There's also a refocus on preventive care and patient control, where preventive medicine is coming back, and it's a lot easier these days to do it via telemedicine than other ways. If you look at the population density in the United States, you can see that we actually are very rural and spread out. And when you combine this with poverty, with medically underserved areas, with health opportunities, with rural healthcare centers, where the elderly are, skilled nursing facilities, and so on, you put all these factors together, and telehealth, telemedicine simply makes a whole lot of sense to be able to reach out to the wide variety and number of people who are in need of healthcare but really have no access to it. This is just an example of why we did it in Arizona. If you can see, well, there's a building right there, sort of in the middle left, and nothing around. That is actually the healthcare center for the Navajo Reservation. And if you notice where it is, it's a beautiful facility, but what don't you see are houses. You don't see a community. You barely see a road. That is a dirt road there to get to it. And patients just simply can't get there. So telemedicine was instituted in places like this and all over rural Arizona to address this problem, because people, the native population, could go, and they would go to their local community center or to the local Hogans, and they would get health care there simply by connecting up to telemedicine to the clinic there or to the University of Arizona, where they provide specialists, because no physicians wanted to go work out there, although it was a beautiful facility. Some of the benefits of telemedicine that we've seen and is in the literature and verified: reduce delays or wait times to get health care, reduce cost, reduce travel, reduce transfers and inconvenience of transfer. There's a lot of specialties, especially trauma, neonate care, where you've got to put people on a helicopter just to get them somewhere where they can get care. And if you can avoid that, your costs and the patient burden just goes down dramatically. We used to have a neonatal unit in Yuma, Arizona, which is about 150 miles away from the University of Arizona in Tucson. And they would get infants there where somebody would suspect a murmur, put this kid on a helicopter, send him to the university, and they say, well, no, there's no murmur. The parents, meanwhile, are driving this 150 miles to follow their kid, and for absolutely no reason at all and at high cost. It increases patient and provider contact, efficiency, patient and provider satisfaction. And there's a lot of evidence in the literature that it improves clinical outcomes, which is the thing we're really after, as well as compliance by patients. For example, diabetic nutrition counseling. We had a program where our diabetic patients who would never ever complete their nutrition counseling were able to do it via telemedicine because it more conveniently fit their schedules. And we think it improves the quality of things as well. Now, any telemedicine program is going to have a variety of components to it. And these are just some of the key ones that are out there. I put this up there just to show how complicated and overlapping it is with your existing practice. Right now, you have financial affairs, you have legal affairs, you have assessment, you have marketing, publication. Putting telemedicine and integrating it into your system adds a few more boxes, for example, like telemedicine training or getting your financial folks to understand how to bill for telemedicine. But the infrastructure, for the most part, is really often there and people just don't realize it. I am an advocate of program assessment. I think every program needs it for a variety of reasons. It can improve your practice. You monitor your practice and what you're doing and so on. Your CFOs are always going to want to know out monitoring costs and benefits. But as you assess your program, there's ways to do it. And this is, if you're just getting into telemedicine and you're wondering, why should we even do it? Will it benefit our program or institution? There's a lot of readiness and needs assessment templates that are out there. This is our version from the Arizona Telemedicine Program. It's a 23-page, really in-depth document that you can send out to whoever you want to participate in your program and really get an assessment of what are they doing now. Because if you don't understand what you're doing now and what your needs are, there's no point in doing telemedicine. If you ask people, well, why do you want to do telemedicine? Well, it's cool. We heard about it. It's going to save all this stuff. And they have to be able to know where and why and when. If you expect to implement it, why that particular clinical specialty? For example, why neuro? Why genetics? Is it because your patients are not getting the service they need? Is it because there's no access? Is it because it's costing you too much? An assessment survey like this is going to help you narrow down the rationale for doing telemedicine. As you're doing telemedicine, I really encourage you to use the SMART acronym in planning your goals. So be specific, deciding on what you want to achieve. How do you know you're going to be done? What are your goals? Make sure they're measurable. How do you know when you're going to meet your expectations? A can be either attainable or assignable, and I think both are important. One, is it realistic? And I'm going to give some examples in a minute, but don't expect telemedicine to cure cancer. It's not going to, but it can do a lot in terms of all those benefits that I did talk about. Assignable, who's going to do it? That's always critically important. And relevant, does it match your mission? If your institution, your department, your division, whatever, is not behind you and it's not part of their mission, you're really going to be out there, treading water alone in order to try to get it up and running. And make it time bound. Make sure your goals are framed in a period of time that you can measure your accomplishments. When you're assessing your program or when you're trying to figure out if you have an impact, there's basically, I think, 5 key areas that you can assess or measure that are very useful. The one that everybody thinks about is patient-centered outcomes. So measuring clinical markers, progress markers. So, for example, if you're dealing with a diabetic population and you're utilizing telemedicine as an intervention, you can measure their A1C levels and see if there's some sort of drop there. COPD, look at spirometer measures, and so on. Provider-centered outcomes. Does telemedicine perhaps increase diagnostic accuracy or efficiency? Clearly, we can measure the time to see patients. An example of improving their accuracy, in our telederm program in Arizona, we implemented it, was all stored forward. And after about 2 years of a steady increase in customers and people sending us referrals, we started to see this decrease. And we were like, uh-oh, what are we doing wrong? You know, what's going on? And so we reached out to the providers and they said, no, 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 you're perfectly fine. But by us sending you cases and getting the feedback as to what the conditions were and how to treat them, we learned. We know what to do now. We don't have to send you those anymore. And we were like, okay, that's good. That's not bad for our telemedicine program, but overall, we had an impact. Business-centered outcomes. Are you getting reimbursed at the same rate with telemedicine as you're getting reimbursed for telemedicine? Is your program sustainable? Technical outcomes. Maybe your network is expanding. Is it faster? Is it reliable if you have a homegrown network? Program-centered outcomes are critically important as well. How many participants do you have? How many contacts with patients have you had over the years? If you were to pick two of these to really focus on, I would focus on the patient-centered outcomes and the program-centered outcomes as things to measure as you implement your program. And these, again, are the types of questions that you want to ask as you're setting up and trying to figure out what it is you want your program to accomplish. Do you want it to drive down your readmission rates? Do you want it to take the place of specialties or specialists that are missing? Is it going to change your referral patterns? Is it going to change length of stay? Is it going to reduce, for example, no-show rates? That's the bane of most hospitals is no-show rates. Telemedicine actually been shown to reduce no-show rates. In terms of evaluation, I'd like to propose a three-pronged strategy that's really easy to follow. And when you're doing reports to say you had an impact, this really accomplishes it. And you don't have to have a PhD to do any of this. Indicators. These are realistic, concrete activities or projects that you can measure in a really easy way. Any of the things that I mentioned, patient-centered outcomes, provider outcomes, and so on. Measure A1C levels. They're realistic, they're concrete. Once you have an indicator, think of a target. These are your goals. Again, they're time limited and they're concrete. I'm going to increase provider contact with my genetic counseling patients by 25% during quarter one. I want 20% of my diabetic patients to have a 10% decrease in A1C levels after 3 months on telemedicine. So get your indicator, set your targets. At the end of the period that you set for the time frame, you've got outcomes. And all you have to do is say, did I meet my target or not? Maybe I succeeded. Maybe I did more than the target. Maybe my patients had a 20% drop in A1C levels. Maybe I had a 30% increase in patient contact with my genetic patients and so on. So indicators, targets, outcomes, and then you can really demonstrate the success of your program. This is a document that the American Telemedicine Association Mental Health SIG created that lists about 50 metrics that are incredibly useful for any telemedicine program. It was developed by the Telemental Health SIG, but these just they cross any kind of program. And if you want a copy of this, just email me. But it covers all sorts of metrics. It provides definitions. It gives you measurements, and it gives some kind of practical observations on what to use. Usability, confidence of care, motivational readiness, no-shows, accuracy of assessment, quality of care, treatment utilization, number of visits, wait times, length of sessions. All of these are incredibly useful metrics to measure the impact of your telemedicine program. Misdiagnosis, patient safety, and so on. So again, if you want a copy of this document, I have it. There are numerous practice guidelines, mostly developed by the American Telemedicine Association Practice Guidelines Committee. I have copies of all of them. There's about, like I said, 20 of them plus an overall core guideline. There's also some human factors ones that we developed on eye contact and lighting for telemedicine situations, as well as the metrics document that I talked about. So again, if you want any of these, please just contact me for copies, because they can be incredibly useful when you've got providers, for example, that are saying, no, I'm not sure, what do we do? Nobody's ever tested this. No, people have tested it, and their peers have established some of these practice guidelines for them. So, and they've been vetted through very rigorous processes. Telehealth resource centers are a group of 14 centers around the United States. They're all HRSA funded. We've been in existence for about 10 years. I'm the co-director of the Southwest Telehealth Resource Center. I'm still 20%. That's what the value of tele is. I'm still 20% in Arizona. There is one here in the Southeast that covers Alabama, South Carolina, Georgia, and Florida. They're located here in Georgia. They're central. They're also the Global Partnership for Telehealth. We each cover one of these areas. There's also TTAC, which is the technology group up in Alaska, and the Center for Connected Health Policy up in California. And the Center for Connected Health Policy, if you ever want to know anything about what the current state of federal and local regulations, laws, etc., reimbursement are, you contact them and they can provide you an overview of what's going on in your state. They provide on an annual basis a document that covers all of the states and gives a really awesome summary of what's going on in each state and how people can get push legislation and so on. So it'll talk about parity laws. It'll talk about the licensure compact and all of that. All the services are free for the most part. If you get into an in-depth consultation, that's going to say like take 10 hours or more. Typically, some of them do charge fees, but most of the advice that they give is absolutely free, and each of them hold a variety of contents as well. So very, very briefly, that was Telemedicine 101 in a nutshell. I think I can open it up for questions. Again, feel free to email me with more questions, plus for any of the documents or any information that you might want. Thank you.